have raised in your speech. Karibu sana Mheshimiwa Duale.
Honorable Speaker of the Senate, the Right Honorable Amason Jeffa Kingi, EGH MP, the Honorable Senator Aaron Cheriot, Senate Majority Leader, the Honorable Justice Retired Stuart Madzayo, Senate Minority Leader, and the entire leadership of the Senate, Senator Jackson Mandago, the Chairperson of the Senate Standing Committee on Health, Honorable Senators, the Clerk of the Senate, and the entire staff of the Senate, ladies and gentlemen, good morning. Honorable Session Chair, I will both have my speech and my team will also project the presentation on the screens so that members can follow the numbers. Honorable Speaker and Honorable Senators, it's a very distinct honor to stand before you, this August House today, and the journey to transform Kenya's healthcare system has been long and hard, but it's a journey we have to walk together. The Senate stands as the absolute guardian of devolution mandated by Article 96 of the Constitution in order to protect the interest of our counties and governments. And because healthcare is a devolved function, your legislative wisdom, oversight, and bipartisan support are the bedrock of the milestone we will celebrate today. Honorable Speaker and Senators, before I report on our progress, let me address a foundational truth that devolution of health was not a mistake. It was a profound constitutional milestone and one of the greatest equalizers in our nation's history. And that's why today, because of devolution, we have functional level 4 and level 5 hospitals across all our 47 counties, delivering life-saving interventions closer to the people. When this administration took office, we anchored our mandate on the bottom-up economic transformation agenda, and to realize this vision, Parliament undertook a historic legislative marathon, enacting 4 critical laws that form the legal spine of our healthcare system. The first one was the Social Health Insurance Funds Act of 2023, which established the Social Health Authority to replace the National Health Insurance Fund. The second one is the Digital Health Act of 2023, creating the Digital Superhighway for health data. The third one was the Primary Health Care Act of 2023, which operationalized the hub and the spoke model and the community health promoters. And the fourth one, and very, very important, which I'll speak to and I'll need the support of the Senate, is the Facility Improvement Financing Act of 2023, which was ensuring funds raised in hospitals and health centers and in healthcare facilities stay and remain in hospitals. Honorable Speaker and Senators, let us be very honest about where we came from. Prior to the reforms, our system was ailing. We had a very fragmented financing model where NHI paid out more in fraudulent claims than it collected in legitimate premiums. We had no visibility of data of the patient records, and our patient records were paper-based, making portability impossible. When I first took when I first stood before the ministry staff during my maiden speech on 1st of April 2025, the situation was critical. We were 6 months into the rollout of Taifa Care. We were facing public scrutiny, systemic roadblocks, and that time I told the country that I will be a bulldozer for the right reasons. And I was to clear the way for UHC, to crush the bureaucracy, and to build a system that works. Today I return to a very important institution, the Senate, the custodian of devolution, to report on how that ground has been cleared, what we are building upon it across the 4 core pillars of the universal health coverage. Honorable Chair, I forgot, let me just introduce in 1 minute that I came with 4 critical officers. I've come with my PS, Dr. Oluga Ouma, come with the Director General of Health, Dr. Patrick Amoth, come with the CEO of SHA, Dr. Masi Mwangangi, and the CEO of DHA, Engineer Anthony, among other staff of the ministry. They will help me in answer many of the questions. So when the question time comes, I will allow you that they come and sit here. Honorable Chair, the first pillar was sustainable health financing. The transition from NHIF to the Social Health Authority is the engine of our reform. As of 26 February 2026, we have registered 29.7 million Kenyans. We have collected 142.7 billion shillings in contribution, and we have successfully disbursed 105 billion to healthcare providers. We have stabilized the system. We are achieving an average claims settlement rate across all the providers, be it private, public, and faith-based, at a settlement rate of 73% across the board. However, Honorable Speaker and Senators, we must confront the narrative of the alleged loss of the Kenya shillings 11 billion. And today I want to set the record straight, Honorable Senators. And I want to wish to categorically state, looking at you in the eyes, that there have been no loss of 11 billion from the Social Health Authority. This figure, which currently in fact has grown, currently stands at 12.7 billion as of today, represents the claims that were flagged, the claims that we rejected, and the claims that were unpaid by our digital superhighway gatekeeper. So these are money that we have saved. These are money that if NHIF was in place today and was using the manual system, this money could have been paid to providers. And I'm ready to give this 12.7 billion that we have rejected, that we have unpaid for, that we said we will not pay because of number of reasons, because of fraud. I'll give you a data showing how many of that 12.7 billion is from the private health providers, how many we have rejected from the county public health facilities, how many are from the faith-based, and how many are from our own hospital, referral hospital, including Kenyatta and MTRH. So no money has been lost, but we have saved money that were to be paid by the Social Health Authority. And we will give the reasons why we rejected them. A key component of this financing, therefore, this represents money saved, not money lost. A key component of this financing model, Honorable Speaker and Senators, is the realization of the primary health care. We are currently rolling out a service charter to all primary health care facilities across the 47 counties. Because our people, when they go to the primary health care, they are supposed to be treated, to be given drugs, to go through the lab, and they go home as long as they have registered with the Social Health Authority. But we have incidents where some facilities were co-charging. So we have introduced what we call a green was the first one. Today is a distinction of being the first facility to successfully roll out this charter. This charter is our promise to the people that at level 2 and level 3 facilities, a Kenyan should be able to walk in and walk out without paying a single shilling. We have already seen 8.08 million Kenyans access these services under the PHC fund, proving that when financial barriers are removed, our people seek care early, preventing complications and saving lives. To ensure that this safety net covers everyone, including the Mamboga and the Boda Boda rider, we have launched the Lipa Sha Pole Pole initiative. We understood that the informality of our economy requires flexibility. This innovative payment model allows Kenyans in the informal sector to make small, manageable contributions towards their health cover rather than a lump sum. This has democratized access to the insurance, ensuring the economic status is no longer a barrier to quality health care. We are currently having 411 011 active payers utilizing this Sha Lipa Pole Pole. So it's working. And so far they have contributed close to 1.4 billion, a clear indication that Kenyans are willing to pay for their health when given a dignified option. Honorable Speaker and Honorable Senators, we are also committing to ensuring that the most vulnerable among us are not left behind. The national government is currently sponsoring 558,000 indigent households under this chief. And this is the data that we have picked from the social protection system, and it cuts across all our constituencies and our counties. I must also commend Murang'a County, which has set a golden standard by fully meeting its statutory obligation, sponsoring 38,000 indigent households and remitting their full annual premium. Furthermore, through the NGCDF and various development partners, we are sponsoring an additional 62,461 households who are under the indigent program. I urge you, honorable senators, to champion this within your respective counties, mirroring this as success to ensure universal coverage at the grassroots level is achieved. Honorable senators, for long, overseas treatment scheme was a conduit for abuse between doctors, mainly in some countries like India, and doctors in Kenya, where cartels and unscrupulous agents exploited the vulnerable patients and the public purse. The era is over. We have introduced a robust, transparent framework for overseas referrals that puts the patient first and protects our resources. This new policy is anchored on a simple principle. SHA will only pay for overseas treatment if the procedure is not available locally. To enforce this, I have appointed the benefits package and tariffs advisory panel, a team of top experts who have rigorously assessed our local capacity. I am pleased to report that the panel has successfully identified and listed 39 medical interventions that are currently not available in our country. These are the only conditions for which the Social Health Authority will authorize payment authorized treatment abroad. Further, we have introduced strict vetting protocols. Every referral is now subjected to a peer review by the Claims Management Office to ensure medical necessity. We are also requiring that any overseas facility receiving Kenyan patients must formally be empaneled and contracted by SHA, just like the way we do it for our own facilities in our country. You cannot just walk out of our country, go to a hospital in India, and then be admitted. For example, that hospital must be empaneled the way Nairobi Hospital and Kenyatta Hospital is empaneled. They must also have a formal linkage with a local contracted facility to ensure that when the patient returns to Kenya, there's continuity of care. So that hospital must have a partner in Kenya to take care of our patients. We have capped the maximum payable amount for those overseas treatment at 500,000 Kenya shillings. This will ensure sustainability while granting access to life-saving. This new framework guarantees that we are not exporting our patients, honorable senators, and we are not exporting our money to support the health system of other nations. That I think we need to make it very clear. We will not export our patients and export our money to go and build the health system of other nations. Instead, we should be investing in our own capacity while providing a transparent safety net for the few complex cases that truly requires it. Honorable Senators, the transition from NHIF to SHA is not merely a change of logo. It's a fundamental restructuring of our national health insurer to ensure efficiency, integrity, and professionalism. We are building a new institution from the ground up, and this requires a fresh, competent workforce. I wish to be categorical that recruitment into SHA is strictly based on merit. There is no automatic transition. However, suitably qualified staff of the former defunct NHIF will be given priority in compliance with the law and the court order. The days of nepotism and incompetency are behind us. Only those who prove their worth will serve the people of Kenya. The second pillar, Honorable Speaker and Senators, is comprehensive healthcare information technology system. Honorable Senators, to ensure efficiency and integrity, we cannot manage what we cannot measure. Through the Digital Health Agency, we have successfully digitized and linked 10,277 health facilities with 4,149 public facilities fully running on our Taifa care system. We have delivered over 30,087 digital devices to facilitate across the country. But this system is more than just a digital record book. It's a fortress. We have deployed an advanced artificial intelligence and big data fraud engine. This engine records every transactions and detects anomalies, billing patterns. For example, upcoding, fabricated records, duplicate claims, impersonation in real time. It is instantly blocks suspicious claims for manual forensic review before a single shilling is paid. It's through the AI and the big data engine that we were able to detect the anomalies that led to the 12.7 billion shillings in rejected claims. And let me also make it to the senators that this is from April to November. I'm yet to go back to when the SHA started, October, November, December, and January. And when that is analyzed by the system, because the system that time was very young, there was a lot of manual, then more and more claims would be rejected. Honorable Speaker and honorable senators, we did not wait for the media to expose the scandal. We are the whistleblowers. In fact, the 11 billion came from an interview I gave to the nation. And if you read, if you leave the headline of that day and you read the content of inside, it has a different story. Guided by the data from this engine, the ministry has initiated several purges. We have formally submitted 1,188 files of fraudulent and non-compliant claims to the Director of Criminal Investigation. Currently, 248 healthcare facilities across the country are under active investigation by the DCI, and we have the documents to table. The DCI has forwarded 30 case files to the ODPP, with 9 cases already pending before court. Senior people, including 2 former CEOs of SHA and key members in the Claims and Accounts Department, are facing criminal charges in court alongside the facilities. 26 suspects have been arrested and charged, including facility directors, former SHA officials who collude to bypass the controls. We have aggressively, Honorable Speaker and members, executed financial recoveries, recouping close to 305.8 million through administrative surcharges. And this is where facilities, when we face them with the records from the system, some facilities say we are ready to reimburse the monies that we took, which now has been found that that money was not ours. So we have recouped close to 3 or 5 million shillings. And over 3.2 million via the administrative alternative dispute resolution by the ODPP. When the files went to the ODPP, the facilities went to the ODPP, and they said we want to handle it. And that process is underway to recover another further 817.3 million. We have further secured our digital sovereignty through a historic collaboration with the United States of Government. Through the data sharing agreement, which I have sent to both houses, we have signed. And we are upgrading our health information system to a world-class standard. Honorable Chair, when I send those 2 documents, those 2 agreements that we signed with the US government, I asked the chair of the Health Committee that I am ready and willing to come and explain to the representative and the leaders of our people. And I'm waiting for a date. Honorable Speaker and honorable senators, most importantly, this partnership guarantees that for the first time, we're in full control of our data. All health data is now locally hosted, adhering to our data protection laws, ensuring that the health records of Kenyans are secure, are sovereign, and are used primarily for the benefit of our planning and resource allocation. Pillar number 3, Honorable Chair, Honorable Speaker, and honorable senators, is human resource for health. No system can function without the hands that heal. We have ensured that all UHC staff engaged under the previous contracts continue to offer service without disruptions. We have all resolved all the standing issues regarding medical interns who are now being paid strictly as part of the collective bargaining agreement rates, ensuring that we treat our future doctors with the dignity that they deserve. And on UHC staff, Honorable Chair, Honorable Speaker and Senator, I really want to bring to the attention of the Senate that we have agreed with the National Treasury, Public Service, that these people must be transitioned now to the counties, and the salaries and their remunerations must be seen in the division of revenue bill that will come before. as part of the equitable share. At the grassroots, we have formally recognized, paid, equipped, and digitized 107,000 community health promoters, transforming them from volunteers to frontline soldiers in preventable health. To sustain these grassroots heroes, I have specifically requested the support of the Senate to implement a joint national and county co-payment framework for their social health insurance. That come July, both the national and the county governments co-share that we give our frontline 107,000 community health workers a premium health insurance. The fourth pillar is on health products and technology. We are reforming KEMSA, Honorable Chair and Honorable Speaker and members, into an agile, transparent logistic entity that uses digital tracking to secure the last delivery of medicine. Many Kenyans now are telling us there are no drugs at the last mile. I urge you, Honorable Senators, to actively support and encourage the county facilities to purchase their medical commodities directly from KEMSA, as we have adequately capacitated and supplied authority, and now its refill rate is at 89%. But Honorable Chair, I think it will come under our discussion, Honorable Speaker and Chair and members, that the law you passed, FIF, is not being implemented very well. Some of the money are being returned back to the county treasuries. And there's a report we have to that effect. The money must stay in the health facilities. It will help them buy drugs. It will help them recruit healthcare workers on locum. It will help them improve on their infrastructure. So the Senate should help me enforce the implementation of the FIF Act. Honorable Senators, I must highlight the strategic importance of the USG Kenya Health collaborations. This partnership provides over USD 300 million annually in support of our malaria, HIV, and TB closest programs. As we move towards the sunset of some of this international support, we are pivoting towards local manufacturing of health products to ensure our long-term health security. To ensure specialized services reach our counties, we are implementing the National Equipment Support Program. Critics have attempted to compare this with the old rigid, flawed management equipment service they call known as the MES. Under the MES, counties were inadequately consulted, but under the NEST, the National Equipment Support Program, we have signed intergovernmental partnership agreements with all the 47 counties. NEST is a very strict fee-for-service arrangement. We only pay for utilization. The county government does not buy, the national government does not buy, the vendor is paid based on that strict fee-for-service. And that reimbursement will be done through the through the Social Health Authority. We have already invested under that NEST program, when I quantify the equipment in our county hospitals, close to about 6.18 billion to install modern diagnostic machines like CT scan, digital X-ray in 120 county facilities. And let me give an example of King Fahad Hospital in Lamu. Today I stand here and I have been there. King Fahad Hospital has a fully fledged running ICU, both even for pediatric. Today it has an oxygen plant, today it has a CT scan, today it has a private wing, and many of the people in Lamu Island used to travel all the way to Mombasa. Today they don't need to travel, and that happens in many of our counties. Our referrals numbers have reduced drastically by 60%. We have also heavily invested in specialized capabilities and maternal survival. Under the Every Woman, Every Newborn, Everywhere agenda, we have launched a rapid result initiative in 26 high-burden priority counties. we are drastically strengthening emergency obstetrics care and blood transfusion service, because no mother should die while bringing forth life. Honorable Senators, let me be very clear today that the next agenda, all of us as leaders, we need to deal with is maternal and new child-born mortality rate in our country. Mothers are dying. Children are dying. When mothers walk to hospitals, they are not patients. They go to health facilities to bring life. They should not die. And that's why we started the Rapid Result Initiative in 26. We have mapped out the country. We have found out 26 counties have very high burden of maternal mortality rates. The Kenyatta National Hospital has reached a world-class milestone, I want us to give, by establishing the state-of-the-art HLA lab for organ transplant matching, effectively ending our reliance on expensive foreign laboratories and cementing Kenya as a regional hub for medical excellence. A number of tests that we used to send to CDC Atlanta, to South Africa, today can be done at Kenyatta Hospital. Beyond our borders, we are positioning Kenya as a leader in global health security. Through the Kenya National Public Health Institute, we are expanding our laboratory networks, emergency operations centers, and we are building a resilient system capable of detecting and responding to pandemics long before they reach our borders. We have just this week reduced the restrictions for our citizens crossing to Ethiopia after WHO and the Ethiopian Minister for Health have confirmed to us that Marburg is no longer a threat. Honorable Chair, Honorable Speaker, Honorable Senators, what are the challenges and what are the legislative interventions that we require from the Senate? While our progress is undeniable, we face critical challenges that require your direct legislative and budgetary intervention. The facility improvement financing implementation. While Parliament, the two houses enacted the FIF Act to ensure funds are raised in hospitals, stay in hospitals, we are facing an implementation crisis. Counties are increasingly substituting their own health budget allocation with FIF revenues. What do I mean by that? Today, I am sure the Public Investment and Accounts and the Health Committee will agree with me. The own source of revenue in our counties, the health sector accounts for between 60 to 70%. And because of that, some counties don't want to allocate the ordinary resources from the equitable share to health. And two, as I said, we're facing challenges with how the FIF is implemented. I know I will have issues with the Council of Governors because I have a session with them next Tuesday. But I think we must face the reality and we must tell each other, however painful it is, because Kenya must change. Revenue retained by facilities must be treated as supplement to and not as a substitute for the equitable share. Two, legislative harmonization. To secure the standard of care, I bring to your attention a bill before the National Assembly, the Quality Healthcare and Patient Safety Bill, which is currently before the National Assembly's Departmental Committee on Health. We need your support when it arrives there to expedite that passage. Furthermore, there is a pressing need to review and harmonize the existing health legislation to ensure conformity with the Constitution and the UHC agenda. This includes urgent amendments to the Health Act, the Public Health Act, the Cancer Prevention and Control Act, the Pharmacy and Poison Act, the Mental Health Act, and the Nuclear Regulatory Act. Just to go back to the Quality Care and Safety Bill, Honorable Chair, Honorable Speaker, Honorable Senators, care for many years has not been defined. The care of our patients has never been defined. You will see there were 2 mothers, 3 mothers sharing one bed. You'll see patients on the floor of hospitals. That is no longer the case. And how did we solve it? We solved this using the digital superhighway. As we sit here, we can tell the bed capacity of each hospital in our country. And we introduce in the system bed access rule. And every hospital can only admit based on their license. If their license has 50 beds, they can't admit 51. So this bill is so critical because it's defining care, it's defining safety, it's defining how our patients should be treated. The patient should be the boss, not anybody else. Lastly, exchequer release and budgetary support. We need support from the Senate. Finally, to sustain this momentum, Honorable Chair and Honorable Speaker and members, and clear the backlog, we require budgetary intervention, which rely heavily on your support. We need an exchequer release of 5.9 billion for PHC fund to clear pending claims and ensure seamless, free primary health care. It's budgeted, it's not been released. Dr. Mercy has to pay PHC for the month of October, November, December, and January. I had an engagement with the Treasury. They say they will release before the end of today or Monday, but still, I think the Senate must be cognizant, and I must tell the Senate that. A supplementary budget of 11.9 billion to cover the projected PHC deficit up to the June of 2026. We have also allocated 2.04 billion to fully operationalize and support maternity package to safeguard our mothers and newborns, particularly in level 2 and level 3. When the architecture of the Social Health Authority benefit package was done, level 2 and level 3, where a lot of our mothers in the rural areas used to go and access to deliver, were left out. Now we have quantified and we have looked at the financial burden, and at the summit of 10th December, it was agreed that now our mothers should deliver at level 2 and level 3, and SHA should get the reimbursement, and SHA will get 2 billion to fully operationalize that. Finally, Honorable Senators, the state of our healthcare is transforming. We have moved from a defined NHIF to a surplus generating share. We have stopped the hemorrhage of public funds to cartels and redirected it to Mwananchi. I request your continued support. There are many things I can say that I've never seen in my entire life in public duty. You have seen the DPP flagging and charging 9 facilities, their directors, and even some of the staff of the Kenya Medical Practitioners Council. The place was rotten. We have a pending bill of NHIF, and this is how we agreed to deal with after we do validation. We have said 0 to 10 million of the old pending bill of NHIF, amounting to 5.3 billion, accounting for 95% total bill of legacy bills of NHIF, will be put in a supplementary that will be presented to Parliament next week. The balance we have agreed after we are doing validation and scrutiny will be put in the budget of 2026 to 27. 2026. So it's not always a service for I'm also a victim.
Yes, yes. So everywhere I go, Kenyans were asking me, what about? There are many facilities. Let me be very honest. There are many facilities facing challenges because of the legacy debt of NHIF. But now we have found a solution. Honorable Chair, just to finish the current issue we are dealing with, and we are just Just giving you a tip of the iceberg. Fraud in healthcare is about 30% globally. Today, even our colleagues in the private medical insurance, they're facing the same fraud. In fact, if social authorities suspend a facility, all the other insurance companies will suspend the next minute. That's how fraud is. We are now investigating parents who are submitting claims of their dependents, their children. One household is submitting 137 children. Another 140, another 150. When I submit that list next week with the facilities to the DCI, it's a difficult job, but I have to do. It's a difficult job. I looked at it last night after the system, so that is some of the things that we bedevil every day. We have a facility, I don't know where the senator of Bungoma is here. Yeah, we are monitoring on 24 hours a facility in your county, because the system picks and profiles. So now these Kenyans who are submitting, I mean, I think the person with the highest number of children in our country must have been Kuku Danger. Kuku Danger had 140. Nobody else has reached there. So we are facing all that, but we are ready, we are willing. I have never missed any session of the Senate, both plenary and committee. I have never, the clerk is my witness, I signed statements. I give it priority, and I am ready, willing to answer any question this afternoon. Thank you, sir.
Asante sana, makofi mengi.